Attendees are in listen-only mode.
We'll reconvene this meeting at the break. My name is Rick Cooper. We have a small but mighty group. Welcome on this Monday morning. Today's objectives for our HILN meeting were included in the material that was sent to you last week, I believe. And by way of reminder, we would like to reflect on our work of the past 2 years and in your role as an ambassador and an accelerator of implementing great ideas to transform and improve our healthcare system. And then as we pivot to think about our priorities on a go-forward basis. Next slide, please. So we, it's an interesting period of time right now. Isn't it fascinating? I don't know about you, but it was a hell of a weekend. And there's just so much change and uncertainty generally, and we'll get into what are potentially the implications for what we do. And this morning, I think that this uncertainty about repeal and whatever replace might be is a topic that will inform our work. And so I'm hopeful we have 2 or 3 separate periods of time that we're going to allocate. Paul, how are you? Paul Gruen, former colleague of mine. Good to see you. It's informal here today. So, but this uncertainty related particularly to what replace is going to mean for the financing and organization of healthcare delivery around the country, but our concern is specifically in Washington State is something that we need to think about. And I don't know about you, I find myself worrying a lot, and maybe unnecessarily worrying, but I'm worrying a lot because there's so much good work that has been done in a marketplace that has been noted for certain attributes like collaboration and focus on the patient and trying to add value that these times of uncertainty can be anxiety provoking. I would like to do brief introductions for HILN members and our guests. And for our guests, in a few minutes, if the tables aren't full, you're welcome to join the group for a discussion. So maybe we'll start here, Peter, with you and do introductions. And I also would like maybe to deviate a little bit from past practice, either now or in later in the meeting. I'd like you to reflect on any learnings you've had over the last couple of years and application of those learnings in your marketplace or organization. Or secondly, totally unrelated, as we think about the future, recall that we're now halfway through the HILN grant. And we're just starting the Medicaid demonstration project. So my second request is if you have issues that you think are appropriate for this conversation, I'd invite you to offer those now or later. So Peter, we'll start with you. You're one of my heroes, Peter.
This could be a long conversation, so that's fine. So I'm Peter Morgan. I'm on the Family Health Centers board out of Okanagan. I'm also on the North Central ACH board. This has been an interesting journey, and I admire the strategy of standing up all these ACHs. I think it's the right thing to do, and I'm also daunted by how difficult it is to create a bottom-up grassroots healthcare improvement process over a huge geography with no resources. But that said, I think we have made some progress, and I'm excited about the possibilities. And there certainly is the desire on a lot of people out there, to work together. And it's a question of how we lead, enable, and support that. That's the challenge. It's the right strategy to do it from the bottom up, and it's challenging.
Good morning. I'm Regina Delahunt with Whatcom County Health Department. I'm also on the North Sound ACH board. Just before we started, Peter and I were talking about the ACHs and in relation to the waiver and the toolkit and all the things that are coming down. And I totally agree with Peter. The ACHs are kind of still in the formative stages. And so it's really daunting to start thinking about how we're going to get this work accomplished, even with a year of ramping up. I think we're probably still a year too soon for the ACHs to really have their firm grip on what's going on. So I think that's a real challenge, and we really need the leadership that we have here to help the ACHs really stand strong. Yeah.
Thank you. If I might just pause for a second. Nathan, this morning in his remarks, will offer some observations about current state of ACHs. And I know everybody knows this, but I'll take the opportunity to remind everybody that our work goes beyond accountable communities of health as well. And so Nathan will comment on integrated and coordinated care. Financing matters, so how we transform from our current financing system into something that rewards value, as well as behavioral health and integration with physical health. So those remarks will be part of this morning's presentations.
Good morning. I'm Ron Vivian, representing this morning Washington State Council on Aging. I'm a citizen advocate and community volunteer. I may be one of the only people on the HILN group that is not involved in the industry. But I would tell you that the aging community right now has terror in their hearts over what's going to happen to Medicare. And that's a high interest area for this group, and one that I think hopefully will get answers that will not continue the terror in their hearts.
Good morning, John Weisman, Secretary of Health. I think my observations over the last 2 years are that there have been many opportunities for us to engage, and sometimes it's hard to figure out which opportunity to take at which moment in time, and that we have to keep connecting the dots for folks and helping them see how all of this fits together. And from a public health world perspective, I think just impressed with the opportunities there are to connect from everything from the clinical preventative services to community clinical linkages to the upstream policy work, and that there are resources needed, I think, to help folks do that efficiently and effectively.
Good morning. I'm Amy Goings. I'm the president of Lake Washington Institute of Technology, representing the Community and Technical College presidents.
Good morning. Jürgen Unutzer. I chair the Psychiatry Department and the AIM Center at the University of Washington. I guess I would say that in our discussions and dialogue, we've come a long way to really think about the fact that health is more than just the absence of disease. I think we're now talking in a big way about public health. We're talking about mental health and substance abuse care being part of all health care. And I think we're starting to see examples that if you, in a smart way, integrate health services in a more patient-centered way, if you can provide all of the services that a person needs, behavioral health, physical health, you actually can improve health and get cost reduction. So it's really nice to see that.
Good morning. I'm Nancy Gento with the Washington Health Alliance, and I guess I would reflect on a couple of things. One, in the reports that we are going to hear today from all the co-chairs of the accelerator committees, there's a constant theme woven around transparency of data and information, and we're making progress in our state, but not everywhere we would like to be with that. And I think continuing the hard work of interoperability and all that goes into that is key. Another reflection I have is, although we're very strong in this particular group with healthcare folks, and we have Brian here from the Department of Commerce, we really haven't tapped into major employers yet and gotten their interest in this endeavor. Not for lack of trying on the part of many, but we haven't engaged that really important part of our market yet as fully as we need to.
Maybe a brief pause. Nancy, why do you think that's the case?
I think in part because big business in our state is generally doing very well. Their issues are really around recruitment and retention of staff. Doing things that impact or perceive to impact employees through value-based purchasing is just a tough nut for them, not their biggest priority. And
what about small business?
I think more interested, can't do it alone, need guide paths for how to make that happen. Still tough.
Thank you.
Good morning, Andre Fresco from the Yakima Health District. The last 2 years have been a period of great optimism here in the state, but the reality of life is that we have many sobering events. So I think actually the work that we've done in the last 2 years is going to pay dividends with the uncertainty at the federal level. So I think this will only position Washington State to be a leader through these difficult times.
Thank you.
Good morning. I'm Brian Bondlander, Washington State Department of Commerce. And I just want to observe that taking stock of events of these last couple weeks and if not days helps remind us the importance of working together and developing more resilient communities through, in this case, a healthcare system that works for our community, because a lot of things can happen that are completely outside of our control, and a lot of things are probably going to happen completely outside of our control in the coming years. And so I think it speaks to the importance of what we're doing here. Thanks.
Good morning, David Wertheimer with the Bill and Melinda Gates Foundation here in Seattle. And I think my observation over the last few years is I have been, the Gates Foundation, of course, in this country focuses primarily on education. And we've been exploring the relationship between the social determinants of educational success and the social determinants of health. And I sensed those circles were somewhat intersecting at the outset, but they are more than intersecting. They are, in fact, contiguous. They are exactly the same thing. So I'm really interested in how, as this work unfolds, we look at our efforts to promote health and from a social determinants perspective, recognizing that as we do that, we're also going to promote social determinants of educational success, which are, between the two of them, essential pathways out of poverty for people in our state who are furthest from opportunity.
Hi, Preston from Providence. Thinking about the last couple of years, I thought this has been a great process of both kind of a ground up and top-down focus. And where we've ended up with kind of the toolkit and where we're launching from is a great set of programs, I think, that make sense and that are going to drive us forward in terms of improving the health of our populations. if we do this well, it'll really not only transform our Medicaid and Apple Health programs, but transform our other health programs and payers throughout the state, I think, in total, kind of using the state as its first position. I really see the evolution of the systems of care. We've been very siloed in the past. This has started those communications in our communities of really different organizations sitting down, leveraging the dollars and resources that are available. We're going to be much better off for that. And also, I'd say an incubator for innovation. I'm starting to see a lot of that in terms of how people are thinking of using new technologies in the communities across systems of care to really drive that change as well. So I think it's a great start. We have a lot of work to do ahead of us, and but it's going to be fun to be involved with.
I'm Caroline Whalen with King County, and it was my pleasure to serve on the Collective Responsibility Accelerator Committee. And through that work, as well as reading through the material in today's packet, I am amazed at the breadth of what is happening in Washington State. I agree with previous speakers that the work before us is daunting. It's daunting if we have clear alignment at the federal level, and I guess I don't have an adjective to describe what it is, you know, in the current situation. But I agree that we have to move forward as a team, and it's great that we've been pulled together in this group.
Nathan Johnson with the Healthcare Authority, and I think I'll have an opportunity to share some reflections in just a moment.
Thanks, Nathan. Good morning. I'm Kathleen Paul from Virginia Mason, and it was also my privilege to serve with David on the and Caroline and many other people on the Collective Responsibility Accelerator Committee. And when I think back on the work that we've done, one moment stands out for me, and it was actually a cross-committee call that we had not long ago when Andre pointed out that the connections we've made and the relationships we've developed really will lay the foundation for our work going forward, despite anything else that's happening in our environment. So thank you for that.
Good morning. I'm Nicole Bell at the Cambay Grove, and Andre and I will be reporting out later today on the Rural Health Innovation Committee, which we've been really privileged to chair together. And so I think he made some really good remarks, and you'll hear plenty about our experience and our thoughts.
Good morning. I'm Janet Varon from Northwest Health Law Advocates, another non-industry affiliated organization. I feel like in this period of time, we have made a lot of progress, and we have a tremendous responsibility to hold ourselves out as a model for the rest of the country in what can be done in a state that actually has a constructive and collaborative process to move people forward, including vulnerable people. And we're going to be incorporating the Medicaid waiver work and implementation in this next period of time, which is, there's been a lot of work gone into the development of the waiver, but implementation is another thing entirely. And I think we're going to be, of course, as everyone said, implementing at a time of uncertainty, but also with a lot of people who we and others are hearing from who are just scared out of their wits about what might be happening to their health care. One of the things that's important in this process is the collaboration, and we have been advocating for the inclusion of and engagement of consumers in this process. And, you know, again, it's going to be even harder in a way because of the current environment, but I think it's essential to, in all of our work, to make sure that as we do care integration and as we do development of the project selection and the various other parts of the waiver, that we really meaningfully include consumers. And proud member of the Communities and Equity Accelerator Committee, which I think will have a great responsibility in the next period of time to do that.
Good morning, I'm Aaron Spark. I'm the Government Affairs Officer with the Seattle Indian Health Board. I'm also on the Communities and Equity Accelerator Committee. Very happy with that. I think we have an extremely large task that we're all taking part in right now, moving forward together to transform our healthcare delivery system. And I think that's a great thing. It's not easy. It's extremely hard. I think all of us have been frustrated, but also really happy with some of the successes. But making sure that we have a stable foundation going forward, which gives us a little bit of a certainty. When you look at it at the federal level, which we've been talking a lot with our contacts over there. So at the Urban Indian Health Institute, which I also represent, we have contacts in 7 states. So, and many of them are, and it's bipartisan, and we actually have a really good opportunity right now. We can be certain with what we're doing. We know what we're doing, put a stable foundation down. The uncertainty that's happening in DC can work to our advantage in a little bit. You have to think of it as an opportunity. So we have to make sure that we're putting forth a good model and let everybody know we're doing that. And while you're doing that, while there's uncertainty with voting because of all the different states that have expanded Medicaid who don't want to vote for a full repeal, make sure that we're contacting everybody and letting them know about our model and that there is good that can come out of this. And that's for everybody involved. So rather than, we have to make sure this is bipartisan and everybody understands that good will follow good.
Good morning. Excuse me. Good morning. Winfried Danke with Choice Regional Health Network and the Cascade Pacific Action Alliance, so one of those 9 accountable communities of health. And as I reflect on the last 2 years, 2 observations. One is as an ACH lead support person, I'd say it is possible to bring communities together across sectors. I think we've demonstrated that. We've built a great foundation. In our region, we have had the good fortune to actually get into some project work, and it's all youth focused. So to me, it reiterates that if we want to get to better health, we have to move into the upstream world, into prevention and early intervention. And I think we have some great early successes in that area. That's one observation. So I'm optimistic looking forward from that perspective. The other observation is from my role as a co-chair of the Community and Equity Accelerator Committee. I do think we have a very broad body of work that we need to push forward, and now it is even more important than ever, I think. There will actually be more asked of the committee and frankly of all of us to make sure that we move that spirit forward that I think we all carry.
I'm Bob Crittenden with the Governor's Office, and I want to make 3 observations. One is we've always been an exceptional state, and I like to think of ourselves as being exceptional. And I think the work being done in the state has been really very constructive. I think we're only halfway there, and what I mean, I think that there are a lot of people have done a lot of good thinking and some good work, and we have the opportunity over the next 2 years as well as over the life of 11-15 to actually make, I think, relatively huge changes. We have a bit of a obstruction that everybody's talking about, but I just think back to the times of, say, a couple other presidents in the past where we were stopped nationally, but in that same time we worked locally and we actually made big progress locally that finally was helpful as the national scene changed. And I'm optimistic that we need to continue doing what we're doing and really implement the things that we're talking about so that we can be either a model and can move this forward as we move into the next stage. But I appreciate all your work on this. Thank you.
Hi, and I'm Doug Conrad. I'm the principal investigator at the University of Washington of the evaluation of the state innovation model, which of course is part of the larger Healthier Washington. We are trying to ascertain over time, over the next couple of years, the extent to which the work that you are doing does advance the goal of better health, better care, and lower cost growth in the future. So that's our task. We're partnered in this work with the Group Health Research Institute, the Center for Community Health Evaluation, led by Alan Cheadle at Group Health, and also with our colleagues at the Research and Data Analysis Division of Medicaid and DSHS. I'm thinking of Bev Court and David Mancuso. So this team is trying to look at the range of what's happening with the ACHs, the hub, the payment models as they are implemented, and the overall impact of this activity. And we appreciate the opportunity to be part of this great work.
Hi, I'm Laura Pennington. I'm the Practice Transformation Manager at the Healthcare Authority for Healthier Washington. For the sake of time, I'm just going to pass it on.
Hi, Laura Kate Zeichkin, HCA. I want to take this opportunity to recognize the people who are on the phone from HILN. As I think you know, we have a webinar option for those who cannot make it, but it is a listen-only option. So we have Jill Sells from Reach Out and Read, Tom Martin from Lincoln Hospital, Peter Rutherford from Confluence Health, Anthony Chang from Empire Health Foundation, and Gail Fast from ESC 105. And Peter, do we want to?
Good morning, Peter Adler from Molina Healthcare. And reflections on the last 2 years. I think I would have said this 3 months ago, but in the context of Washington, D.C. and the changes and the inspiration of this weekend and the ACLU, I want to emphasize perhaps a few points. First, that while am I proud to be part of Washington, and I believe we have been and we are, and I think the country's going to look to us to continue to be a leader, to set a course, to do it with evidence-based principles, and to and have guidance that's based on a set of guidelines and data. Second, that the leadership that and the risk-taking that's gone along with Washington in the last 2 years, we've all been asked to jump into change that's disruptive, and it's not easy. And we're watching, I think, this country be very aware, suddenly becoming aware of when change can be too disruptive when it doesn't have direction versus when it does. So from that, my reflection is the great achievements that we've made in reducing the rates of uninsured and underinsured in this state, the great improvements that we've made in improving access to care for those who heretofore did not have access to care, the progress that we've made in terms of affordability, the progress that we've made in terms of integration with behavioral health and physical health has been our direction and should continue to be our direction. And we're going to have to demonstrate, I believe, take the lessons of the last 2 years around collaboration that all of us have learned that none of us can do this alone. All of us need each other, and take those lessons from the last 2 years and let them guide us for the next 2.
Good morning. I think I'm just introducing myself. I'm sorry I'm late. Diane Oakes from the Washington Dental Service Foundation.
And brief introduction of our guests, and then we'll...
Sure, Michael Garrett. I'm a principal at Mercer.
Hi, Bruce Smith. I'm the Executive Medical Director at Regents.
Alexander Fredheim, consultant and programmer.
Hi, Paul Gruen, former colleague of Mr. Cooper, and for about 10 years, and currently pleased to be with the BRIE Collaborative as implementation consultant.
Hi, I'm Jenny Weir. I'm the director of the BRIE Collaborative, and I also help staff the Clinical Accelerator Engagement Committee.
Bob Perna, Washington State Medical Association, a member of the Clinical Engagement Accelerator Committee.
Good morning, Leah Rosengaus. I'm a director with Cope Health Solutions.
I'm Jack Thompson with Cedar River Group and the Washington State Public Health Association.
Hi, Dan Monahan with Novartis. Good morning. I'm Patrick Evans, the new CEO of Sound Mental Health in King County. Not only new to Sound Mental Health, but also new to the state of Washington, here from Ohio, and happy to be here in the state of Washington. Welcome.
Good morning. I'm Sophia Aragon. I'm the Executive Director of the Washington Center for Nursing, and I'm also a member of the Communities and Equity Accelerator Committee.
Good morning, Sarah Kwiatkowski. I work at Community Health Network and Community Health Plan of Washington and Public Policy.
Sybil Hippolyte with SEIU Healthcare, 1199 Northwest, and I'm also on the Communities and Equity Accelerator Committee.
Well, thank you for volunteering. Peter, thank you for leading the way, fella. You did a great job. If Dorothy were here, we could hear her reflections, but she isn't, so she's in the other Washington, D.C. But I want to take a moment to recognize Dorothy. And she is a person I've gotten to know much better over the last 2 or 3 years. And she is a very competent, bright, capable person with a lot of passion on the subject of improving health of all citizens in Washington. And in her world, it can be a brass knuckle game. And so she has comported herself with dignity, has helped lead this group superbly. We miss her today, but think about her. And I thank you for joining me in recognizing Dorothy as an outstanding leader in healthcare in Washington State. I want to particularly thank Janet and Ron for reminding us that we're here about patients and to focus on patients and to really listen to voices of patients. And in that regard, we have listened to you and really tried to capture the voices of those who are impacted by our work and those voices of patients that we need to hear from. This morning you'll hear 2 or 3 vignettes from folks, and I think now we have ready to call up our first voice of a healthier Washington.
I'm employed by Columbia Wellness, and Columbia Wellness is a nonprofit here in Longview and Kelso that provides behavioral health care to adults, children, and families. I wanted to really get back to seeing what was really in our community, and working in community health has really opened my eyes to what our community really is. I think Longview is a city of contrasts, beautiful homes, beautiful parks, beautiful trees, to areas where it's been highly impacted by poverty, by domestic violence, by drugs, all of the things that go with all of those components. We have a lot of people living in poverty, and they need our help. It was a Friday afternoon. I had finally connected with this family. They were there, and I went to the door and I asked to speak to the mom, and she reluctantly came to the door. One of the first things I asked her was whether or not they had food. So I went and got some food and took it back to them. Well, the mother was really appreciative that I did that. That was actually the student that was referred to me because they had a deformity in their lip and palate that had not been addressed. The first issue was to get them into their primary care, and it was a situation where they had no-showed many appointments, and the clinic had told them that they would have to go elsewhere. They got the referral for a facial cranial expert down in Portland. They ended up canceling it for 3 months in a row. It was canceled. During those 3 months, the mom totally lost ability to get any housing and became homeless. And with that, the children went to live with the father, who also lives here in town. And sometimes they're so overwhelmed with what they need to do. They need the person that's going to help them take that first step. And granted, you may be helping them take a first step multiple times, but eventually you're going to get that success. Some of the successes were actually the child ended up being removed from the home. I'm sorry. But that was a success because they're not in the environment where they're afraid for themselves. They're not in the environment where they're being subjected to drugs and violence and really bad things that we don't even have a clue about. Longview and Kelso were cities that are trying to redefine themselves. So I see it as a city of contrasts, but I also see it as cities that have a lot of hope.
Thank you, Laura. I'm going to invite Nathan to provide a Healthy Washington update. Nathan, you're on.
Let's see. All right. I am on. That's good. Well, good morning, everybody. I'm going to keep this brief because we actually do have a fairly packed agenda. I would consider this meeting, and I think Rick has well introduced it as such, as our midpoint assessment. In particular, midpoint assessment of what it means to accelerate this work as the Health Innovation Leadership Network, and to particularly reflect on the accelerator committees, their successes, and their next steps. But as part of that, there are some significant program updates that I want to deliver for you this morning, as well as some brief reflections on what has taken place over the last 2 years. And before I go too much further, I should make it known that today, this morning, we received our official notification of receiving year 3 of this grant, totaling $23 million, which allows the work of the State Innovation Model Grant in particular to move forward under the cooperative agreement. This may not sound as much of a milestone for a 4-year grant that has already been achieved, but let me tell you, I'm very happy to stand here today with an approved year 3 grant for moving forward. It's good news.
Congratulations.
One of the interesting things that the feds have done with this grant program, and I think it's a telltale of things to come, is it is a cooperative agreement. And I think this is good for the federal government to be doing this. They basically make us reapply for this grant every year, showcasing the work that has occurred, showing what milestones have been achieved, what are yet to be achieved, and in this year they've actually stipulated terms and conditions by which they'll be measuring our collective success over the next year's time, and we'll be looking forward to sharing more of that in detail with this group as the months go on ahead of us. But year 3 is in tow, which is good news. The other thing that has transpired since the last time this body gathered is on January 9th, just a few days ago, we were able to announce formal agreement, not just agreement, but terms and conditions being signed by the federal government for purposes of the 5-year Medicaid transformation demo, which now takes us through 2021 on a trajectory building off of the foundation of Healthier Washington, but allowing us, with our federal government's help, to put a $1.5 billion investment infusion of resources into transformation work focused on the 1.9 million Medicaid enrollees in this state. So a very exciting time, and this group will be very engaged in that work. I should also take this as an opportunity to be explicit in our intent here. We've always framed it as such, but I want to come back to it, and that is Medicaid transformation, and I think it was Preston who might have mentioned this earlier, is as much about Medicaid as it is about the broader health system. These are major changes that for certain will directly impact nearly a quarter of the population, more than a quarter of the population served by Medicaid, but it's the same providers, the same health systems, the same people in this room who are interacting with the whole system that will be partners in this work, and that will be seeing changes move forward. And so what I mean to suggest then is this body, the Health Innovation Leadership Network, yes, has been focused up to this point on activities related to the State Innovation Model Grant. But more and more you will see the infusion, as Janet indicated, of implementation activities for the demonstration being brought back to this group for your review, for your assistance, and for your acceleration. So be looking for that. We are just in the opening days of implementation, and it is correct to think of this first year as a ramp-up year, as others have indicated. So more to come on that. Brief reflections, what's happened over the last 2 years, and we've had opportunity to discuss this, but there's a few things worth noting. Let's start with paying for value. There were 4 payment models that we launched out with in the State Innovation Model Grant, 3 of which are now implemented. Specifically, I want to mention a successful open enrollment period once again for the public employee ACO, also known as UMP+, which expanded its enrollment during this last cycle by 25%. We continue our work with Virginia Mason and UW-led networks to increase that enrollment, but I got to tell you, 25% increase in enrollment for any new state program is a victory. We'll take that to the bank, and we're already working on next year with our system partners. The other thing that's fresh of mind for me is the significant work happening with the business model for Medicaid, and by that I mean the financial integration work of putting physical health resources in with behavioral health resources so they can be effectively managed together. Because the updates have been brought forward and because you've even heard a specific update on integration tasks, I'll just briefly mention that in January of 2018, the next region of our state will be implementing a fully integrated Medicaid model. I had the privilege of being with that group. In fact, Peter Morgan, where are you, Peter? Thank you, helped arrange a fantastic whole-person collaborative event in North Central in the middle of January. We have over 120 people representing clinical interests, payer interests, and community interests, talking about how to make that a success. And I just think when we talk about Health Innovation Leadership Network, the accelerator committees, and how this work is infused into communities, that was a great example of that. And thank you, Peter, for your leadership in putting that event together. It was a tremendous success, and it was a privilege to be a part of it. Other activities include empowering communities through accountable communities of health. As was rightly noted before, accountable communities of health are just one tip of the spear. There are many, many interlaced activities moving forward, but accountable communities of health are critical because they reflect that this work isn't simply state top-down purchasing initiatives. This is community up. We have great representation of the leadership around accountable communities of health in this room today, and that leadership and that capacity will be incredibly vital as Medicaid transformation efforts are implemented, which, as I think most of you in this room understand, $1.1 billion of provider incentives for the type of transformation work around care models and paying for value will be led and administered by those accountable communities of health. So we're rooting for them. We're also investing in their capacity, and this next year will be a critical staging period for the years ahead for us. The other thing I'll just briefly mention that's occurred since the last time we gathered is the formal launch of the Practice Transformation Support Hub, ably led by Qualis, and moving forward in particular with priorities in the 2 regions that are doing fully integrated Medicaid, Southwest Washington and North Central Washington. So stay tuned, and we'll have a more formal Practice Transformation Support Hub update in months to follow to this group, but some exciting work occurring in that department. So I think I'm going to wrap here. There are plenty of other things to say, but I'm going to try to catch us up on timeline a little bit and invite Rick back up here with me. We've already started this in the way of introductions this morning, but we wanted to provide plenty of opportunity for this group to weigh in on a discussion looking ahead to the priorities of HILN. And part of that is understanding best from your perspective where you feel like your organizations and your own level of leadership can contribute, as well as reflecting a bit on what accomplishments have occurred by virtue of this group meeting together, and where we have approached and been addressing challenges in the broader work of Healthier Washington. I'll especially invite our accelerator co-champions to participate in this, but this is an open-ended conversation and everyone is invited to participate. So a few critical questions here that I'll just briefly read to help guide this discussion, and again, plenty to talk about here. The first of which is, what is our role in collectively influencing and partnering with other sectors and organizations to ensure something that all of you, or many of you, stressed in your opening comments, collaborative, aligned multi-sector approach to health systems transformation. What are our anticipated priorities amid anticipated federal uncertainty? And how do we as influencers ensure equity is a demonstrated foundational value in all of the work we do around health systems transformation? And there may be other questions you want to bring to the table. I would welcome those, but we want to get this discussion started with this as the frame. So Rick, would you add anything before we get underway?
No.
Okay. Andre, I see your hand first.
Thank you. Well, one of the reasons that I've been so privileged to be part of this work is that it's creative work. And as a career public servant, it's not often that you have the opportunity to be welcomed to the table to have a conversation of this depth. So I think that you may all be being quite polite at the Healthcare Authority about the willingness to sit at the table and actually ask people their opinion. So I would encourage you to take advantage of how seriously you take the partnership role with industry, with local government, because it's unique in this state to have that. Most of the time you have a period of public accounting or discussion, and then the doors close and government makes their decision. This is the exact opposite. So this is a transparency that is really very effective, and I think would be very encouraging to others who are not familiar with your work to sit down at the table.
Thanks.
Duly noted.
What might others add to the conversation? Thanks, Eric.
So we talked at length during our accelerator committee about this, but one of the things that we're talking about is making sure the voice of the user is in this one, because the Medicaid people who are in Medicaid, I have a very different conversation with somebody who's been in Medicaid as opposed to somebody who's in that churn population. So as a seasonal worker, so sometimes they're eligible for the marketplace, other times they're back into Medicaid, or even where healthcare fits into their lives because they're so busy just trying to make ends meet at that point. And I don't think we're necessarily there. We have a really good group of people who do interface right there with our clients, but actually getting the Medicaid user's voice into this is something that I think we're missing right now. I think we've done a decent job trying to frame it so that we're going to head there, and I know a couple of ACHs have headed in that direction where they're going to have this type of community advisory board, but really getting it in there so it's part of our group, that's part of our group collective, so it's not something that we're just thinking about. We're informed in real time about it.
Excellent point, Nate. How will that be included in the demonstration project, or is it too early to comment on?
We know as a matter kind of policy and directive that consumer engagement around project formation and application is a stipulated requirement of the federal and state agreement. How that will occur around each accountable community of health, as was acknowledged just a moment ago, may be different. And then I think it raises the further question too for this statewide body, how we're reflecting the consumer voice and whether we need to do anything more in this Health Innovation Leadership Network to do that better. And I think we're very open to folks' ideas on how to do that.
Nancy.
Thank you. I want to address bullet 2 here, which is, anticipated priorities. I think that we stay the course and maybe even accelerate the work we're doing and not wait to see what the federal government is going to unfold. And I think as Washingtonians, we are looked to as leaders across the nation, and we should take advantage of that and get ourselves inserted in as many ways as we can at the federal level, advocating for what we know works in our state. And I don't think we can be complacent about that. I think we should be a part of that conversation, framing the direction for the country.
Okay, Nancy, now if I could be so bold to ask you to give us your top 3. So if you're encouraging us to double down on our work, give me your top 3.
Well, I think that the work of whole person health has to go forward. I think that's a really important thing that we've started in our state, and I think we're a model for others. I think the work of the ACHs is very important, the convening and bringing folks to the table at the community level where work can actually get done. And given my own bias here, I would say that transparency of information is key. And not only, do you need data, you need to trust the data. And people need to be prepared to act on information that comes. So it's not just data, it's the trusted value that comes because you've been a part of the process of creating it.
Other comments? Thank you. Kathleen.
Thanks very much. So I just would want to add to that payment for value, because I would want to make sure that we're paying for things that really matter. And if we're not, then we have so much waste in the system that we could be affording to things that are really important. And then also I would say, reflecting on President Obama and what he thought he didn't accomplish, and that was really communicating about all the great work that healthcare reform did for people. People don't even understand that, you know, they took advantage of Obamacare or the Affordable Care Act when they're part of the Medicaid expansion. So it's so wonderful to be here with all of you and to hear these inspirational and motivational words. And thank you, Aaron, especially. And I would just want to make sure that we're not talking only to ourselves. And I think that was part of our mission, and I'm not sure we're there yet, but that worries me.
Thank you. Peter over here.
You know, I've been thinking about HILN and our evolution over the last couple of years of our role and where we go from here. And I think this is in answer to question one is, I mean, there is an incredible amount of, you know, talent and influence in this room, you know, cross sector. But I've noticed that, you know, participation has kind of, you know, dwindled somewhat over the months. I mean, you got really busy people who are trying to figure out where their, you know, where their time is best spent. And I'm wondering how we can make this into a forum where you just wouldn't want to not be here. And I think it might be in, you know, connecting the HILN to the ACH forums or something so that we have a, you know, I'm thinking out loud, but, you know, a bigger kind of forum where you can connect, you know, the broader influencers with the people who are out there at the ACH level trying to make things happen, and that there's, you know, ability to connect the people who have resources and ideas at this level with the people who are struggling at the front lines, I think, to make things happen. I'm just thinking out loud about how do we make it even more dynamic and action oriented. And I would also second what Nancy said about priorities. You know, the measurement, the accountability, the transparency. We've got to be able to drive progress off of information. Thanks.
So following up on Peter and Kathleen's comments, I agree wholeheartedly. And one of the challenges that we were issued at the Gates Foundation on this front not long ago was whether or not we are sufficiently working with, as the stakeholder put it, unaccustomed partners in unaccustomed ways. We have many, many familiar faces around this group. And we had a meeting not long ago at the Gates Foundation with a group of grantees of ours that are working on equity issues, and it was a very, very difficult meeting for people that we were providing support to do their equity work. And the question, the issue they raised with us was are the questions that you're asking even the questions that we're asking? And are the priorities that you're establishing anything close to the priorities that our communities are establishing? Those are really important perspectives that I think we need to pull into this conversation on an ongoing basis, not only from people who are recipients of Medicaid and utilizing those services, the providers, as we just heard from, who are servicing those individuals and supporting their well-being. I think that would create that really dynamic and engaging conversation that will propel this work forward in both the short term and the long term. Because I think we really need to ask ourselves, are we asking the questions that our constituencies really would be asking, and are we establishing the priorities that our constituencies really ask us to be establishing?
Thank you. Rick and I were talking before the meeting started, and I guess it's a question that I don't know enough about, but I'm hearing noises coming out of the BHO's work that talks about the behavioral health side and the physical health side having a challenge playing well together. They're being brought together for a common good, but they're coming from two different perspectives. And I'm wondering if that's something that this organization is or should be involved in.
Peter?
Yeah. Another thought, just building on the great comments about priorities, is that in this next phase of HILN that we pull our eyes back up to the long term. It becomes very easy when engaged in change to look at priorities for today, the things we need to do in 12 months, the money that we have access to through the various grant programs and waiver, all of which is great, but we're engaged in population health and changing the health outcomes, which is a long-term proposition. And I encourage us that we're at a dangerous crossroads at this point if we don't include a sustainability and long-term focus either as into every task force or as its own piece of work. Because our goal isn't the next 5 years, it isn't the waiver, it isn't whole person health alone, it's the outcomes that we're going to get from those for our communities. And that's long-term work, and we're in an environment where funding doesn't work, doesn't come in long-term chunks, and our goals and incentives that all of us have don't happen then. So I just think it'd be great for us to seize that one.
Excellent. So Peter is encouraging us to start with the end in mind. Start with the end in mind and create a roadmap, given all of the uncertainty and change that will increase our likelihood of improving health, improving access, reducing resource consumption, and including the health of the communities in Washington State. Very good observation.
So just one last thing to say, really building on what Peter said. So and I'm guessing a lot of us, not just me in the room, head and do a lot of federal work, but also being able to communicate across lines with different modes of storytelling is what it is. So, our director of the Urban Indian Health Institute says data is a story. So we do tell our story in different ways depending on who we're talking to. But it would be really good to have this broken out in such a way that depending on who you're talking to, if I could talk about it in a human aspect because that's where it resounds with them, I like that. But also to have right alongside it is your ROI or your return on investment aspect. So we're depending on who we're talking to, if they're far right, and I say this with, who's going to be directing the OMB for the next 4 years, and also who's going to be the Office of Monetary Budget and also the Congressional Budget Office, which is very conservative in that aspect. So that ROI aspect, if we can give that return, is really important for us to communicate, not just at the local level, but also up to the federal level. And I know you do a good job because we're also talking about that 2% reduction over, how many years. But having those alongside each other, just so we have the ammunition that we need, walking into whatever arena that we're walking into is going to make the most sense, does help us along the way also.
Thank you.
And I'll just add as a compliment to that stuff is all very important, but I want to make sure that we're always asking people who are receiving services what their perception is of the value of those services to them.
Ron? I have, in light of the questions, comments that we've heard here in the last couple of minutes, particularly David's invitation to ask for input, are we asking the right questions from the perspective of seniors or Medicare beneficiaries from your point of view? Is this group asking the right questions, the issues or concerns of seniors that you are listening to and represent?
I have to admit that when I meet, for example, with my cohorts at the State Council, they have no knowledge of this program. None. I talk about Healthier Washington, and there's a quizzical look on their face, et cetera. So I know there's a huge amount of work going on, and it's a huge amount of work that is going to make big impact, but I don't know that the story is being promulgated out to the population who it will impact. It needs to, obviously, because their method of receiving care is going to change in the process of changing how we deal with the whole person. So from that perspective, I don't know. Maybe I've just got a very narrow point of view, but I'm just not seeing the story told.
Thank you.
It's helpful. Curious and building off that comment. You know, one thing that we don't do a good job of typically is storytelling. That is, and Janet's comments and Ron's, I think, illustrate that pretty well. We have tried various approaches to this through our engagement with multimedia, through some of the videos we'll be seeing throughout today, but even their spread and their relevance to broader audiences is in question. So this group has provided some insight into that previously in the way of a problem statement, and some tactics and approaches have been formed around that. But to address that problem state going forward, and in particular to get the work of Medicaid transformation fully looped into Healthier Washington, which I think to your point, Ron, has a much more direct impact on long-term care. There's a whole initiative focused explicitly on long-term care. I'm curious tactics-wise from this group, and knowing the different audiences you get to communicate with on a regular basis, what would serve you all better in your roles in that way? And by that I mean things we can do and commit to doing almost at a program level to help and assist in that area. That's what I'm...
You know, I want to make one more comment, and I overstated a few moments ago, because the representative to the State Council from Southwest Washington has spoken significantly about the work that is going on there, because their whole healthcare community has established this process of dealing with the whole person. So where it's working in a community, there is knowledge. But outside of that, what's going to happen is the point I should make.
Great. It is a good point. Others have any reflections on that, in particular with tactics or things that we could be doing a better job supporting you all in your respective roles, which is really what this is about?
You know, one of the themes that I hear, and especially from the video that we saw, is, you know, we're asking consumers to be engaged, and folks can't be engaged if they are focused on housing and food and bare necessities. So I appreciate that this group includes housing, and I think some in the state are looking at that need in pretty creative ways, like what if doctors could give a prescription for housing, prescription for groceries. You know, I just think we have to start at those basic needs, and it's through you know, dealing with that we're able to get people engaged, and, you know, being honest in the story that that's what it took to get people healthy. And sometimes, you know, when you're dealing with mental health issues, it is getting people to care about their daily care. So even in commercial populations, the Boeing pilot that occurred with intensive care, you know, the nurse had to go to people's houses and get them to go out and walk and take them to the grocery store. So I just think we can't forget that sometimes we're talking about patients who just need help with basic care.
Great. I think we do want to transition at some point to the Accelerator Committee breakouts. And again, as Rick indicated, we're going to have plenty of discussion time built into our agenda today as those presentations go forward. So Jenny, I think you may be up first, and I think we're going to try to squeeze just a couple minutes in, and then we're going to break as soon as Jenny and Winfried have presented, if that's all right with the group. Does that work?
Yeah, Jenny and Laura will update us on the Clinical Engagement Accelerator Committee work,
followed by our Communities and Equity Accelerator Committee update.
Thanks to you both. Come on up.
Well, thank you. You will notice that I am not Hugh Straley. He unfortunately was unable to come today. I'm also not a clinician, so I just want to be honest that we are here to really reiterate what we've heard in our discussions in the Clinical Accelerator Engagement Committee and kind of show our value to you and think about ways that we can move forward in 2017 in ways to carry all of this work forward. But I just want to reiterate, I think that the communication piece is really key and having a clear message, a clear kind of visualization of how every part of Healthier Washington fits together. That's something that we heard from our committee would be really helpful. So where does HCA sit? Where does DOH sit? Where does the hub sit? It's something that we could kind of give folks that says, oh, I see myself in this whole, map of all these different organizations. So the Clinical Accelerator Engagement Committee, we've met almost monthly this past year. We did a survey of our membership to really identify the gaps between our current state and what we called a roadmap to a healthier Washington. I think you have that survey or the results from that survey in your packet, so I encourage you to look at that. And in the survey, we focused on behavioral and physical health integration, value-based purchasing, and the clinical community linkages. So really those 3 pillars of Healthier Washington. And we saw that a common understanding of value-based payment is really necessary. So again, that clear, that consistent messaging about what Healthier Washington is, what it can really do for folks. That data remains a huge barrier, especially measurement, alignment, and common language, and lack of good data that is timely. Folks really talked about that being an important barrier that they kind of continually were running up against. That health information technology is huge, especially EHRs talking to one another. That is a big difficulty, especially around behavioral health integration. And that resources to build infrastructure for change are kind of wanted and needed by the community. So our group really wants to help address some of these gaps, but we really want to also acknowledge that provider fatigue and burnout, especially in primary care, is huge, that our group really wants to help address that and help sort of facilitate understanding of how to relieve this burden while also promoting coaching and clinical improvement or transformation. So going forward, we really do want to help support providers across Washington State. They're really who we see as our customers for this group. We want to continue to meet and really fill this key role of helping providers engage and practice transformation and sort of, I call it sort of translate how all these initiatives align and translate the value proposition. So helping providers understand what is coming down the road, especially with all this federal uncertainty. So this will include alignment with the work of the hub, with what Qualis Health is doing, with the UW resource portal, with work of various associations that are helping facilitate this understanding as well. And then more broadly with MACRA, and again, any changes coming from the federal government. So we've talked about supporting providers peer-to-peer, maybe through regional learning collaboratives or calls. That might be a way that our group can really benefit the community, serving as a sponsor or a convener for regional trainings or summits focused on value-based purchasing and integration, and maybe creating educational materials. We really wanted, again, to have materials that make sense, that are understandable by a wide variety of audiences, so for patients, for providers, for plans, and really that would focus on overcoming common barriers faced by practices. So if this is a fact sheet or an infographic that could help support the priority areas. And we really want to offer this committee as a way to carry forward these conversations. So if that means that other members join this committee or other committees kind of fold into that, so that might be a way to make sense of the work that has gone on before and really carry it forward. Anything to add?
No, I think that was it. That was great.
Okay. So we're moving on. What? Are we doing questions or questions? Yes.
So the survey was phenomenal, and I obviously come to it with a bias of my own organization and wonder, from the two of you, were there surprises there, or what do you think some key takeaways from that survey are?
I think the key takeaways really are a common understanding. I'll put a little plug for the BRE Collaborative's Behavioral Health Integration Recommendations. So common understandings around what behavioral health integration means, and those are out for public comment right now. We just opened that today. I encourage everybody to look on our website and give us feedback. We would appreciate it. Common understandings around value-based purchasing, what that means, what that looks like for a hospital, what that looks like for primary care. Are there ways that we can help support rural providers in that too, and bring people along who are in smaller practices? But that also data is a huge thing. So it's things that we've heard before. I think those won't come as a surprise for you. I think they're all really familiar problems. And I think our question that we're really trying to think of a path forward is how we can help support that really the most.
I think the one thing that I would add to that is that a lot of the organizations that participated in the survey, it was really clear that they're already halfway down the road, but there were a couple, probably the more rural, who did participate, that they rose to the top as really needing our support and help.
So Ginny had a question, and that is the survey was really very interesting information, but you had about 12 people or 12 organizations. So was there any discussion at the committee about expanding the survey so that you get more input from around the state?
Yeah, I would love to. I'm a big fan of surveys and data, and I would love to expand this, and if we could maybe use other HILN members to disseminate that and get a broader number than 12, I think that would be fantastic. We just used our own members in the committee.
And if I could add too, we built that survey off of the survey that was disseminated from our value-based payment team that they released to providers. So we started with that, and then the members of the accelerator committee tweaked it a little bit. So yeah, I think it would be great.
Anybody else? Yeah, Peter?
So I'll just confess that, as an ACH board member, there is a lot out there to pay attention to. I mean, there are webinars and materials, and it's like drinking from a fire hose sometimes, and things go by me that I don't pay attention to. So I think there's an opportunity as our ACH gets its legs under us and to do a better job with that. But one of the things you said got my attention, which is we could help you with learning collaboratives. So one of the things we're trying to do in North Central Washington, and we've actually got the concurrence of all the major provider groups to move ahead with whole person care collectively. And I'm trying to figure out how to stand up a learning collaborative, maybe not as sophisticated as IHI, but something where people are transparent about where they are, where we learn from each other. I think we have an extraordinary opportunity, and we're looking for help on how to do that. So you or anyone else in the room who would like to talk to me about how we run something like that and how we resource something like that would be great. Thanks.
Yeah. I think that's something we'd definitely be interested in helping to support.
I think one of the things too that these committee members see themselves as is they could be peer champions in your communities, but they also recognize that there is not a broad membership across the state. So if there's any members in accelerator committees that may be potentially disbanding and want to join, there's always room for more, especially on the east side. So just put that plug in. So.
Thank you very much, Jenny and Laura, for that update. Winfried, you're up.
So first off, I actually, before I talk about the committee, I would like to make a quick connection, because I think part of what we're trying to do here at the HILN is to make connections, right? And so you saw this video, and I saw a lot of you responded very emotionally to it, right? I did. And I know this pilot really well because this is part of the Cascade Pacific Action Alliance work. So when I said earlier We are deep into implementation in our region already. This is an example of the type of work that we're doing. So I just wanted to make that connection. I also would like to start out by acknowledging many of my fellow committee members here, that several are in the room, and of course also Anthony, who is on the phone. He can hear us, but he can't talk. So hi Anthony. Thank you for your work as well. And so in your packet, you actually have a quick summary of what I'm trying to relate to you as well. So this committee worked really on 4 major themes. The first one is that we wanted to make sure that the voices of the consumers and others that are impacted by our work are really at the table. And this conversation started out with an idea or a focus on accountable communities of health, but I would argue that while that is important to think about that in terms of accountable communities of health, the vision should go beyond accountable communities of health. It needs to be all of us that have to think about that. A second major area was the inclusion of an equity lens. So now we're going even broader. So how can we make sure that in all of our organizational work, we really think about the impacts that our actions have, that we're pondering on those that are directly impacted by that. And we do this every day in our respective businesses. Again, I think we started out with accountable communities of health in mind, but it really affects all of us, and we should all think about that. And we should ask ourselves still the question, does what we are planning to do actually reduce health disparities? That's really the question that our committee asks itself here. The third area is data disaggregation, and this theme of data is permeating, I think, our conversations in probably all committees. In the Equity and Community Accelerator Committee, it came to us in the sense that averages mask distortions, right? And if we want to be able to address health disparities, we need to understand where exactly are those disparities. And so we have to unmask the data essentially. So we have to get more sophisticated at disaggregating our data, and perhaps we need to collect data differently too. So we talked a lot about that in our committee. And then last but not least, we talked about the workforce that is required in our respective businesses and organizations. It should really mirror the diversity of our communities. Our nurses, our healthcare professionals should really mirror the folks that are knocking at our doors to ask for services, so that we can better and more authentically communicate with them, and frankly, someone said it, ask the right questions even, right? We come from it from our perspective, but are we asking the right questions? So those were 4 areas that we focused on, and I think as we were talking about how do we bring this forth to you and make it relevant to you, our question to you is, how do we bring it out of a conversation in a relatively small group of folks that are fairly diverse? We want to bring this to all of you. All of you need to be part of this conversation on how do we diminish health disparities and improve health equity. And how do we take the next step then and make this real in the sense of how can we guide investments, real investments, resources into making sure that we move forward towards better health equity. So those are a couple of questions that we thought might engage you, and we would love to hear your thoughts on how do we get it out of the committee, and how do we make it real in the real world. And my fellow committee members, please chime in if I missed anything.
Reaction, questions, comments?
So this is John Weisman. I think, first of all, thank you for these sort of thoughts and recommendations moving forward. I think they're right on and very helpful. I also think that as we look at these data, the more we can get these data into sort of geographic basis and neighborhood, sort of smaller community, it allows us to do that intersect between the social determinants where people live, play, work in their community and the services that are there. That can be sort of one of those bridges sometimes when we don't have all the data we would like, but it's that place of action and where things, and if we think about, again, we're talking about bringing sort of the the consumer, patient, client, whatever we want to call the person being served into that mix, I think that's a pretty powerful way to do that. So I think we should not underestimate the power of looking at data also by geography in smaller communities to give us the insights of how to best provide service and actually engage then folks in that delivery of service. And if we think about connecting with community health workers and that knowledge base that they bring, I think that's a nice way to bring it together.
So, and I do agree with that fully, but also understanding that a lot of the Medicaid population is highly mobile and low income. So we did point out the KidSat mental health model that was able to follow folks across health and human services, which I think is brilliant. That was one of my favorite presentations of several years now, because they were able to, with one page, look at where everybody was going. Now, that was a Herculean effort, being able to come up with all the MOUs and DUAs and all the bridges that you had to build to follow your client. But I feel like that's one of the things that we'd like to talk about, because I can talk to a client right now, but in 1 month they will have gone through 2 zip codes, and being able to ask them if there's a geographic impact. But that's not everybody, obviously. So I know our native population is highly mobile and low income, and a couple of others as well, especially the migratory workforce. It would be good to be able to follow that across the state. That would be a really good thing, so that continuity of care follows along, and that data is what informs our continuity of care.
And if I could maybe add a thought to that. So our committee also asked, could we maybe ask you all, the HILN members, your respective organizations, to think about what would be even a few metrics that we could all agree on voluntarily to track in the same way, so that we actually have the beginning of a data landscape that would tell us the answer to that question of, where are the disparities and what do they look like? So that's a challenge that we would ask you. Yes?
Sorry. This is Sophia Aragon from the Washington Center for Nursing, also a member of this committee, and thank you, Winifred, for that excellent summary. And I just wanted to highlight the great work at the Department of Health when you talked about workforce and data disaggregation, and just really want to applaud them for applying an ethnicity portion of the survey that's much more reflective of Washington, because to be able to capture it at that detail will get to that local level so that we know better where we have work to do in diversity of our workforce in certain parts of the state. So there's really great work happening now, and again, just really thankful for that work that's going on.
My God. Hey, okay, this one is working. So my name's Sybil, again with SEIU 1199 Northwest. I go to a lot of these meetings, and it's always heavily populated by white people, which does not represent the population of Washington State. So I would just love to be able to see more people that look like me and that don't look like me, but don't look like y'all. It's like more diversity here. So I know there, Aaron, I see you. I know we have Anthony on the phone, but I think that's part of this too, thinking about, within your position of power in your organization. I don't have one, but you all do. What are hiring practices you can do and things that you can do to encourage development of people that represent their communities? Because I think we often think about this as something very big and out of our reach and very difficult to manage, but I think there are decisions we make every day as gatekeepers of various resources that we have opportunities to improve equity within our own sphere.
And following up on that and the idea of being deliberate about thinking about race and racial equity, there are tools. In fact, King County has a very good tool that is used to ensure that groups that are just making decisions are thinking about the right questions and getting the right information. And we have recommended, and we have a report that many of you have seen that recommends and adapts the tool for use by ACHs. So we would really like to see every ACH apply a tool like this as part of the decision-making and deliberations.
And if I may add to that, I think it's important to think about ACHs, but it doesn't stop there. So why not? Why couldn't we all use that tool in our respective organizations as we think about decision making? So I just want to challenge you all a little bit to think about how do we take the really great conversations that have occurred in this particular committee and take it out of that and bring it into the mainstream essentially, and then make it actionable. So this committee, I assume, will continue to work on this question. So we will be back and try to challenge you a little bit more over time.
Thank you very much, Winston. We'll take a brief break and reconvene about 10:45. I'll ask folks to finish up your conversation and take a seat in the next couple minutes. Thank you. We're going to start out with another Voice of Healthier Washington video.
Getting old ain't bad if you handle it. If you give in to it, it's the worst thing in the world. But if you handle it yourself, then you're going to be all right.
I am the program coordinator for Rural Aging with Empire Health Foundation, and I get to work with all the fantastic programs that we fund throughout rural Eastern Washington in working to improve the lives of seniors and elders. Another component of the program is SAIL, which stands for Stay Active and Independent for Life. And this is a senior fitness program designed to increase balance, strength, and flexibility.
I think the number one benefit in this program is independence.
I can't just go out and take a walk for about a mile. I can't jog, so I need some kind of exercise to keep myself going.
Nora is fantastic. She is from the community. She knew many of the elders. They all love her.
We're on the Spokane Reservation, and this is Welfinite Mountain right behind us.
Nora, she's just irritation. I love her like a daughter.
I help Ed Hughes instruct the SAIL class. I'm a Spokane tribal member. I work for the Spokane Tribe of Indians, and I'm a health coach for the Health and Human Services program out here on the reservation.
3, 4, 5. That one really gets in here.
As an 88-year-old man, he is helping to lead the SAIL class in making sure that his community members are fit and safe. He has really taken this program and turned it into his own and really become a leader and a champion of the program.
But I really enjoy doing what I'm doing, and I enjoy the people I'm doing it with.
I only come up here once a week, but I look forward to it, and I think it's done a lot of good for me.
We work on getting them to take control of their health on their own, learn to talk to their doctors, take care of their medication management, just any goals that they have for themselves to be healthy. I help them reach those goals.
They get quicker and quicker. Hand-eye coordination.
I would tell these people and people that haven't come, why are you sitting home on your keister when you could be maintaining your health?
There's been a 58% reduction in hospitalizations for program participants. We've also seen a 68% reduction in readmissions for participants.
I can do all these exercises at home too, because Ed has kind of conditioned us now. So you have it in your head.
And I really enjoy being with them and seeing old people get up and get around.
We're helping somebody's mom, we're helping somebody's grandma to improve their quality of life, help them age with dignity in their homes and really remain independent as long as possible.
This program is doing amazing. We have tons of data on how the program, SAIL, the health coach program, how it's all decreasing the numbers and our elders are becoming healthier.
I hope to be 100. maybe 110 if I can stand it.
Fantastic. All right, we'll continue on our spotlight of Healthier Washington Accelerator Committee reports, and I'll invite up Nicole and Andre to talk about the Rural Healthcare Innovation Committee findings.
Thank you so much. Well, first off, I want to thank the Healthcare Authority for all their tremendous support, not only from staffers who have helped with our committee, but also I want to thank Nicole for allowing us to have such a great spot to meet and to really be a valued member who brings a great deal of support from non-traditional partners. So we're here to talk about the Rural Accelerator Committee. And when we began this process, we were talking about something that was deceptively simple, which is value-based purchasing and how to create more opportunities to talk about money and the transfer of money and how money can translate into better services. And it became something far, far greater, something far more in-depth, something more close to the things that we've all been talking about, which is how do you create opportunity in rural parts of the state, representative of the entire United States. How can you create opportunity for people living in rural areas who are isolated, often impoverished, often suffering from historical changes that did not benefit them. And so it really became something more fundamental. And what we really came to with great struggle and great conversation was the reality that your health is determined by your zip code. Your health is determined by your zip code. So all the great work and all the great hardships and sacrifices that hardworking parents make who love their children, however imperfectly, and all the great work of all these wonderful providers providing all these great services is impacted by your zip code. And we feel that that is just not acceptable. So it's more fundamental than just money. It's not just having the right people in the right positions. It's far more transformative. So that's really what we began with.
So over the course of time, our committees met often in person at the Canby Grove, sometimes by phone, and we had a strong benefit of meeting in person. Some of the benefit included storytelling, and I'm going to tell one of the stories that we kind of crafted when we thought about the realities of today and how to imagine a new day for rural healthcare. But some of the other anecdotes that we heard that we just wanted to share today were sort of like jaw-dropping for many of us on the committee, such as a rural health community on the coast who was seeking to fill a primary care physician job with limited office hours and on-call hours, about a 35-hour work week, with a salary price of $250,000 and couldn't fill the role. We also heard instances of rural health clinics in the middle of the state making investment decisions in an EMR for tens of millions of dollars, and we thought about the care that could be provided or some of the alternative spending that could be done instead of the investments that we hear about and are being made. And so we did a compare and contrast of, two people growing up in different zip codes of the state. We called them Jacob and Michael, and in your packets there's a little 2-page, actually I guess it's 3-page handout that tells the story. And so Michael and Jacob's little map and compare and contrast are on the second page. So I'll just read the narrative that we put together for our committee about what life is like for two individuals who start out similarly. So both Jacob and Michael are native Washingtonians, both in their mid-20s, both love the outdoors. They each have deep roots in Washington and love living in the Northwest. They're quite similar in many other respects, with one main distinction that it's impacted the course of their lives. Jacob's from a small rural town on the Olympic Peninsula, and Michael lives in Spokane. Growing up, Jacob's family earned less than $40,000 a year, and his family didn't have consistent health insurance. For most of his childhood, Jacob was either uninsured or on Medicaid. Fortunately, Jacob wasn't ever turned away from the clinic in the local critical access hospital, but he never really sought out health care unless he needed it. And so often his first point of contact was walking into the emergency room. Michael's family, on the other hand, earned close to $80,000 per year and had private insurance from his dad's employer. Michael was able to get regular checkups and with his primary care doctor, and as a kid, he had braces to make sure his teeth came in straight. As a farmhand, Jacob's dad had a less formal education, and though his parents pushed Jacob to get a good education, Jacob loved living in the small town and wanted to follow in his dad's footsteps and get into farming. There were only a few kids in his high school class, and some of his friends had dropped out and were making money, so he didn't really see the importance of school. And as a result, Jacob never graduated from high school, and now he has a hard time finding a job. Michael, on the other hand, graduated from high school, went on to the University of Washington to become an English teacher. Michael now works for the local school district teaching high school. His job offers him paid sick leave and full medical benefits. Due to the stress of Jacob's life, he smokes and struggles with depression. Though his primary care doctor has referred him out to a mental health specialist, the drive is just too far for him to make his appointments. Michael did have a short bout of depression, but he was able to access a therapist through his health insurance and get the support he needed. And now he's doing just fine. So this is a fictitious story, but it's nonetheless a common one. At the end of the day, Jacob's more likely to die younger than Michael simply due to the fact that Jacob is from a small town in a rural community. And so the question that our committee really fought with over time is, do we in Washington State believe that our zip code should determine our health? Or do we believe that anybody should be able to live anywhere in our state and have an equal opportunity to live a healthy life?
So this is really a fundamental issue that we talked about, and when we talk about health equity, we often talk about the idea that it's equal. But really, if we're talking about health equity, should there really be a distinction between rural and urban care? Should there be a distinction between the type of care you receive regardless of your background or your pocketbook? It really should be far, far greater than that. So we have an opportunity here, and I would share with you that the members of our committee were really energized by this, want to remain involved. And so I know the Healthcare Authority is very excited about the idea that this can continue and have far more of a greater impact. So we're working on problem statements and bringing a playbook, as we've referred to it, to the Healthcare Authority. We recognize that it's not ours to do. We're working with our partners. But again, the idea of a first mover in Washington State is critically important now more than ever. So our problem statement, and again, this is one of those things that got hashed out, but I wanted to read it to you. The problem statement is, the sustainability of rural healthcare delivery depends on fundamental transformation and must consider the unique nature of rural and isolated constituents and scarce resources. The transformation must pragmatically embrace health resource availability and redesign the system with enhanced patient engagement, innovative healthcare interventions, and population health strategies, all leveraging modern technology platforms. One of the struggles that we had was we started trying to, again, fix things, since we're can-do people, and we wanted to come up with solutions, and we wanted to create projects, and we wanted to make investments. But the reality is far greater than that. It's not enough to make an investment and hope it works. The importance is to transform the whole concept so that we view rural care differently in this state. And that is fundamental, and it's going to take a long, long time to do.
So also I'd point to the handout on the first page. There's sort of a little diagram about why we felt that we had kind of a unique opportunity to make a difference in rural healthcare in Washington as a committee and going forward. And it hinges on three elements. First of all, with vision. So we all came to agreement on not just our problem statement, but things that we could do to address going forward and imagine a new day. Fundamental committee work that we did included getting organized and on the same page, to be frank. And so we worked on kind of a first deliverable of the state of rural health that will be part of our playbook, and that helped us create sort of a vision of where we need to go, since we're pretty, we're pretty well documented on where we're at right now. The second thing has been, I think, rehashed many times today is that Washington State is a first mover, and so why couldn't we be a first mover on rural health care as well? And so, you know, just to repeat a couple things that I heard today, we just saw a wonderful example of how we have unique approaches to aging in place, the integration of physical and mental health, behavioral health, the work in palliative care, the patient decision aids that are made available for Washingtonians now, social determinants of health, and other things. But we also have this other unique environment that's occurring parallel, but a little bit outside the traditional industry of healthcare. And we had a lot of those committee members on our committee, which would be sort of the technologists in the state. And so we think that we have this unique environment that we ought to figure out how to take hold of and harness for good. So we are, I put a little bit of factoids at the bottom of the first page, but basically we've got these unique attributes on a national scale with being a technology nexus and being poised for timely interventions. We heard today from the BRE Collaborative, the Washington Health Alliance. We are a part of the country that's much less fragmented than any other markets, and we ought to take advantage of that. And then finally, there is a great opportunity for large and small technology companies to get involved in rural health. We had some of these folks on our committee, and so we learned that the issue is not that technologists are not paying attention or that they don't care. It's that a good case for them to invest their time just hasn't been made yet. And this is an opportunity for the state to have value creation and a win-win, and probably a necessary piece to have some breakthrough. And so, Nancy, this might be a way to involve some of the large employers. We could start with the technology or our consumer-focused businesses. They know how to get patients involved, and they can be put, the resources like being the cloud center of the world ought to be put to bear for this region. And so we also imagine that meetings like the HILN there's probably other rooms in other states in the country where they're having meetings that are similar to this, but we actually can aspire to lead and galvanize communities around innovation and expect a positive result. I liked the comment earlier today about being an incubator for innovation in this state. And so what does all that mean for rural?
And when we talk about what does that mean for rural, we're really talking about our ability to speak for those who have no voice, to really speak for those who have no voice, who have difficulties and obstacles that we can't even dream about before we're even talking about the changes to a rural healthcare system. I mean, we're talking about decades and decades of investment that we've made in the current system. So the idea of re-envisioning that system now is going to be more than just the inputs. So the group came up with 7 areas of focus that they thought were critically important for a vision for rural healthcare in Washington. The first is that the health conditions and risks for all rural community members are determined so they can actively participate in their own healthcare goals. So it is patient empowerment. But it's not just patient empowerment in the sense that they're empowered in the patient care visit. It's that they are empowered to be responsible for their own health. Now, we realize how complex it is to get people to that place, but believes firmly that they are our partners in this process. The second is that primary care is redefined to include things that we know to be important but is very difficult. So when we talk about telemedicine or virtual care teams, we want to move past the idea of using technology and just create better medicine, better health interventions that obviously are based on, in many ways, technology platforms. We want to talk about the importance of patient satisfaction, but not in the traditional sense of were you satisfied with your visit, but are you satisfied with your health? So the idea of engagement is more than just the patient care relationship with the physician or the nurse practitioner. It's, do you feel engaged in your life in terms of the continuum of your life? The fourth is that you're enabled to support new strategic partnerships with technology. One of the difficulties that we came across was the idea that technology can break down walls, but the reality is that you have a lot of legal relationships, strategic partnerships, memorandums of understanding, who works for whom, who gets paid, who gets reimbursed, who's encumbered. It's very, very complicated, and we actually have to have a system in place to organize that so that the patient doesn't see that, but that it's all there nonetheless to support it. We want to redefine how we talk about the total cost of care. And one of the areas that we felt very strongly about is that the total cost of care is reduced by a certain amount, depending on reducing the disease burden and outcomes so that they're on par with public urban settings. The idea that the disease burden is on par with your neighbors who live in urban areas, who may have a stronger transportation support platform, who may have proximity to clinic settings, it's different. It's not something that we often talk about, but nonetheless that was an equity factor we felt strongly about. And the last is we want to be able to continue to support these kinds of incredible collaboratives so that so thinking about this is more than just strategic impacts for the users of these systems, but the idea that you create these opportunities to have thought leaders continue to engage on how this can work. I think that's one of the things we found most energizing about this is that there are people who care about the same things as we do. They just come from very, very different fields of thought, backgrounds, but I really want to share with you kindly how humbled I've been that many of you have been talking about the same issues of equity, of partnership, of integrity, regardless of your disciplines. So that really has resonated, and we feel that we need to create a venue for that so that these conversations continue. So that's where we left it. We certainly want to ask you, though, to be willing to be part of larger conversations because we realize that the issues of rural care are going to be complex and you're all very smart people and we want to be able to ask you to be part of this conversation because we're going to be positioning this again to be knocking on the door of the Healthcare Authority in the future.
So the final questions that we would have for the group in our call to action is really who should own this going forward. We're going to have sort of the beginnings of a playbook and a framework that we're going to hand over to the Healthcare Authority, and how do we move forward in the next couple of years. And second, what are the immediate next steps? Andre pointed out, we really wanted to get some tests and some pilots going, but we were not funded to do so at this juncture, and so will we hand off with some ability to affect change? And then can we demonstrate leadership in our state? Do we want to serve as a beacon for national and global health problems? And are there alternate funding mechanisms that could demonstrate viability in an initially targeted community? And so I think what we mean by that is what are sort of micro pilots that we can get going, and the vehicle to spread could be the ACHs. So we're talking, even smaller little things that could make a difference. And how do we kind of get that going? And then finally, how do we believe that we should determine initiatives in the next 2 years as kind of ongoing committee work? And if so, where and how do we go about doing that? Questions or comments for us? Ron?
One of our conversations at the Council on Aging has been related to rural health, and there's a lot of, because we have members from all over the state coming from a variety of different perspectives. And there's a considerable amount from the rural individuals that are dealing with rural areas. There's a lot of concern about the ability of a 80-year-old woman with diabetes to be able to stay in her home when she loses the ability to drive herself. So transportation is a critical issue. It is fundamental to getting a person to a place. For example, having a medical test. Electronic medicine is wonderful, and for an 80-year-old it might be a little challenging to figure out how to use it, but it's wonderful. But when you need that medical test and you have to go to a lab to get it done, et cetera, that's where the breakdown comes, and individuals are being forced to leave their homes and go into higher expense-based living conditions because they've lost the ability to be able to transport themselves. So transportation needs to be a critical part of our discussion.
Yeah, and transportation, of course, came up. Andre, could ask you to weigh in, but what actually came up more, at least from the technology perspective, was that convenient care is accessible, and coming to you is accessible for all of those things and will be, and we just need to figure out how to do it. So that was kind of an amazing part of the discussion, and it was fun to be part of this committee and see lights go off about things that are happening sort of on the entrepreneurial front that leaders of rural health communities had never heard of. And so there was a little bit of the ability to imagine a new day and to think of things differently that we really wanted to harness as part of this committee. Do you have anything to add?
Well, in public health, we work on things called complete streets, where we're talking about the idea of having a complete understanding of health and when we plan for our communities. And it is amazing the well-intentioned folks who have worked in creating urban planning and lifestyles to realize that sometimes we don't think about the full spectrum of life and the difficulties that people will face as they remain vitally independent. So when you're talking about things like transportation planning, the support systems we have, the whole reason that home health was created was to create a means for people to stay in their homes, but also because it theoretically could cost less and improve health. So these are long-term changes that are just part of the beginning of the discussion, and really a lot of the investment is going to be in the areas of social determinants of health. So you're perfectly correct.
Just a comment. As one of the people that lives in a small rural community, I'm actually involved in healthcare transformation, if you will, at kind of the town level, at the county level, at the regional level, and now at the state level. And what I'm always struck by is how local the issues are and how local the solutions have to be. It's people who know people in communities who work together across, agencies and so forth that make the difference. And one of the things I'm trying to figure out is how you make, how you get involvement at that level and how you get the solutions to be scalable all the way up. I can see it happening, but how we institutionalize that process or, code the DNA of that, the different tiers so that they support each other is, it's an aspiration.
That came up a lot too, and the committee didn't have answers, but the committee did believe that the policy making and the way that things need to be funded did include allowing for a great degree of local latitude and flexibility, knowing that one solution might work for one area, but can it be tested in a small way, and the ones that could be validated to be spread, then allow it to go to something slightly bigger. That's what I mentioned about the ACH, because this came up just constantly, is a centralized approach that would spread out innovation to everybody just won't work for everybody. So.
Yes, and as a provider of local public health, one of the things that has been different in this state and this specific process that I'm really encouraged by is that this has been decidedly unacademic. It is great to talk about what we want and what is idealistically possible, and it's far, far, far more difficult to actually get into the meat and potatoes of why there are obstacles and why there are difficulties and roadblocks, and getting into, exactly as you mentioned, how local communities can start to overcome this. So you're talking about change at the granular level. You're talking about empowering people, as we saw just now, at the local level. You're also talking about intense system transformation at the, I would share with you, very technical and complicated way that you negotiate contracts for hundreds of millions of dollars. It's all happening at once, and that is different. It's very complicated. I think it can be a little daunting. It certainly can create a lot of migraines, but I think that it is unique in this state because often it can't be accomplished at the same time, and nobody wants to because it's hard. So this is very, very unique in my experience.
Thank you very much. Excellent conversation. Opportunity. Think of the end point, and we'll create our roadmap. Okay, Kathleen and David, look forward to hearing your reflections in your committee's work.
Thank you. And Rick, you did such a nice job of recognizing Dorothy at the beginning of our meeting today. And you know, Dorothy has a co-chair, and that's you. And so thank you, Rick, for all the great work that you've done. Your investment in this has been really key. So thank you. So before we get started, we also want to thank Laura Kate, who's done an amazing job of supporting, guiding, cajoling, motivating our group. So thank you so much for all the work you've done, and thanks to our engaged committee members. And I'm sure it will come as no surprise to the people here that Caroline Whalen, who's on our committee, was a strong and consistent voice throughout. So thank you so much, Caroline, for everything you do. So our team had the goal of promoting shared accountability and collective impact in achieving improved community health. And we were so fortunate to have an intern, Marco, pronounce Marco's last name, Petzock, who was at the Gates Foundation, and he took a deep dive into the work we were trying to do. And Marco gave us some great observations, and together with other committee members, we identified 4 levers, which will start to sound like the never-ending story here this morning, that we think are really important in moving this work forward. And the first one is role definition, so making sure that everyone's voices are heard. Medicaid beneficiaries are speaking for themselves. We're allowing them to answer questions, and frankly pondering the questions that they ask us, not really rushing to an answer. So that's important, and really understanding those community connections. The second one was having a common language. We understand, as we've done this work, that for social supports and health supports, many times we're talking about the same things, but we talk about them in different ways, which makes it harder for us to draw immediate connections. So what is the common language we're using to talk about this work? The third thing is data that follow the individual, that don't live exclusively in a payer database or an organization's database. And we're encouraged to hear about the model that Secretary Weisman described here this morning, because that sounds like it would be a real move in the right direction. And then the fourth thing, and I know this is something that doesn't really tug at our hearts, but financial systems that create the right incentives and alignment for us all to do this important work. So I think it's to you, David.
Okay, so this on? Okay, so in sort of 3 buckets of recommendations or thoughts that we have. The first one relates to a lot of the conversation we've had this morning, which is that really the collective responsibility mantra is that the ACHs and the healthcare reform movement in this state really need to engage a broad range of stakeholders if we're truly going to be innovative around the issue of social determinants of health. It goes back to Ron's comment early in this meeting about so many different organizations and constituencies that are not yet connected to healthcare reform in the state, may not even be aware of who their ACH is and what their ACH is doing and how important that is. And that really was highlighted in the report of the previous committee around rural health and Nicole's stories about Jacob and Michael. And if you think about Jacob's story, which is so illustrative from the peninsula, how his health trajectory and the costs of providing health care services to Jacob could have been changed if early on there had been involvement of his school, of the expanded learning opportunities after school that might have been available to him in the community, if employment services and job coaching and job readiness skills were part of his accountable community of health, if you will, how those 3 things in just a short story about Jacob would have impacted his trajectory both in life and the expenses that he incurs in relation to the delivery of health care to Jacob. So really the first big recommendation that we bring to you, and it's written up in the documents that you have, is really to ensure that a broad range of stakeholders are present in your conversations about healthcare reform. We provided one little example in a model of how, for example, early learning programs and how essential it is to engage early learning programs in conversations about healthcare, both from the perspective of parents, and parents as the child's most important first teacher, and the role that parents play in brain development of their children, et cetera, but also how early learning programs need to partner with accountable communities of health to ensure a healthy trajectory for kids in life starts really early and really effectively.
And we did put together 3 communication tools, the first of which is really still a work in process, but it was an audit of all the work underway looking at what are the cross-sector connections. And as David mentioned in your packet, there are 2 examples in the early learning area, and it's frankly because they have spent so much time thinking about the important inputs to make kids successful, and certainly there are many, as David just mentioned, but we've got a fact sheet, and these both really serve as a model, a fact sheet to support stakeholders in articulating why those multiple sectors are important, voices at the accountable community of health tables, and then the second one is a fact sheet, again serving as a model to assist with this conversation at the HILN. And thanks to Doug and the early learning team, who really are out ahead of a lot of us at this point.
And then finally, and this is a bit sort of repetitious, but repetition is a key to learning. The goal that we set of having the Healthcare Authority, the ACHs, healthcare systems and players around the state really work to engage with other systems and to partner in ways to help individuals and communities maintain healthy lives that dramatically contain costs in the primary care system. And here we've talked this morning about a number of them: housing, and the housing systems and the systems that are working to promote affordable housing or to address the needs of kids and families that are homeless. Nutrition, the importance of nutrition and nutritional learning and nutritional access to healthy foods. Education and the social and emotional development of children. The development of executive functioning around decision making, which is critical to healthcare related decisions that we make. Employment, and also organizations in communities that are focused on equity and inequities, and ensuring that, again, those unaccustomed partners are at your table talking to you in unaccustomed ways, challenging what you're thinking in terms of the communities that we're serving, particularly underserved communities of color. So all of those players we constantly need to remind ourselves, especially as we were reminded this morning, given the complexion of the people in this room, that it's really essential for us to constantly remind ourselves that we need to bring these unaccustomed partners to the table if we're really talking about transformation of our healthcare system.
That's it for us.
Any questions, comments, observations?
Or Caroline, did you have anything to add?
Thanks.
So we're rounding the bend here, and we want to hear from you about how we transition from ideas and concepts and collaboration to action that will in part form our agenda. So this will be the final moment for you to weigh in. This is the third opportunity for you to be engaged and weigh in on this conversation. So as you're thinking about this, I'm going to go out of order and share with you some of my reflections as I pivot off this role. and it's worth what you're paying me for these comments. It's the sum total of my knowledge of being in this industry for 40 years, but informed by the last 2 years of learning from all of you. And this is kind of sort of like a Letterman top 10, but this stuff I believe in. And these issues you've heard spoken to this morning, and this will be the last opportunity I'll get to reflect these observations with you. Not in order of priority. Number one, this is all about focusing on our patients and people. And we can't frame this conversation in any other way. It's not the financing system or the organization of the delivery system. This work really needs to be considered through the eyes and lens of the patients that we care for. Number two, damn, this is a complicated system. It is really, really complicated. And when you sprinkle in the reality that we live in such an affluent time, it offers the opportunity for mischief behavior. It's complicated. There's wealth, and it leads to all kinds of different things. But actually, the comments I had written down were shared by Peter earlier. It's really important, given how complex this is, that we start with the end in mind and have a roadmap and get above the cumulus periodically, because we are going to have fits and starts, and it's going to be frustrating, and there will be politics, but we have to start with the end in mind. Collaboration, in part because it is so darn complicated, nobody is going to figure this out alone. And this is going to require public-private sector collaboration. And as I reflected in my earlier comments, I worry about this notion of public-private collaboration, given the state of affairs on the other side of the country. And the other part of collaboration, Peter Morgan talked about too. I mean, all healthcare is local on the neighborhood level. I grew up in a poor town in the Upper Peninsula of Michigan. I wish Peter lived in Sault Ste. Marie, Michigan, because it was 5 hours from nowhere and another 2 hours to get somewhere. And when people got sick, you flew to Everett, Washington, or you went to the Mayo Clinic, or you went to the University of Michigan Medical Center. And where are the leaders in these small communities that can try to connect how care is organized and delivered in these small communities, and then regionally, and then at the state level, et cetera. This is surfaced not necessarily in this meeting, but previously. We have a health manpower shortage up and down the pole. And Boeing's done a pretty darn good job talking about all the engineers are going to lose. We got a manpower shortage, and it starts, but it's not limited to primary care physicians, but nurses and medical assistants, other allied healthcare professionals, and we need to be very aware of the imbalance that is going to occur over time. Much discussion today about social determinants of health. This conversation is far more than just about the medical care delivery system. I can't add too much of that to that conversation. David did that, and Kathleen very well just a moment ago. Affordability, number 6, affordability. You know, my daytime job, our board of directors approved a few years back a North Star. We want to reduce the cost of care 25% over time. It's too damn expensive. Let's get a life. The care system is too expensive. And so one of my favorite research sources, USA Today, has an interesting article, what's happening in India about driving down cost of bypass surgery. Right? Just a price point and how many cases are done, and You know, what are the learnings of what's going on in that country to this country? Equity. Number 7, equity in the broadest sense. And how can we not consider this on a go-forward basis? But beyond what we've heard today in terms of thinking about it, zip code or geography, socioeconomic, gender, ethnicity, etc., I think a lot about this in terms of ethics, the ethics of equity and end of life, and the very, very real difficult issues our caregivers need to consider in a world of limited resources with how much money is spent at a life, and the importance of ethical conversations at all levels, but for this purpose within the provider community to really consider how we judiciously consume resources. The number 8, the primacy of quality and safety. We talked about evidence-based medicine. Much is talked about quality. We need to improve the safety of the care that we provide our patients. Number 9, accountability. We all have a role to be accountable, not only as leaders or patients accessing the system, but everybody from the legislative branch to the executive branch to the regulators to providers to patients to financiers. Number 10, speaking of finance, all financing matters. Now it might not be too far from the truth that all roads lead to the bank and not to Rome. Whoever got it wrong, it's not to Rome, it's to the bank. And our delivery system, it merely reflects the way care has been financed. And so this is surfaced. I personally think it is extraordinarily important to get this right. And at one extreme, my bias is prepaid care is the way to do it. But we live in a pluralistic financing system, but having aligned incentives, appreciating limited resources, rewarding value, all are critical. Number 11, you're going to like this one, Nancy, transparency. And I think about this in a world of a very mature market. And what's to keep the consumer safe other than transparency? In the fullest, broadest way, transparency, pricing, quality, access, in a language that patients understand. So just on the topic of pricing, what if every provider of care listed prices that the patients would incur in a world where patients are paying more for care? You think that might be a leveler? Think that one might be a leveler? Every other part of our society economy has that. Why can't healthcare? And I'm near the end of time, but I could go on and on about transparency. And I'll conclude before we open it up for discussion with number 12, optimism. Optimism. I'm darn optimistic about our opportunity and potential to do great things in this region. We have special people that live here. And we have this, there's something in the water. I don't quite get it, but it's in the water here in this region where people actually respect one another. They believe in pork. Pork. Do you know what pork stands for? Being proactive, open-minded, respectful, and kind. That's how we relate with one another against this backdrop of very, very complicated business. And we have a value-oriented system already in comparison with the rest of the country, but just think about the opportunity for improvement. And so I invite you, as we consider our work, HILN work over the next 2 years, our Medicaid demonstration project work over the next 5 years, to be optimistic and patient and engaged. So with that intro, let's open it up for conversation about...
But before we do that, come on up here with me, this direction. And I'm going to invite 2 members of our Healthier Washington governance group, John from the Department of Health and Bob from the Governor's Office. Rick, you've been with us in this capacity for 2 years now with your sage words of wisdom and advice. And I wanted to read just a quick note from Dorothy, who wasn't able to be here with us, and just a few of my own reflections. Your experienced, innovative, and creative leadership during this fast-paced time of health system transformation has been invaluable. Your hallmark skills of bringing people together, challenging the status quo, and encouraging us all to focus on service improvement on behalf of the people we serve has left a deep impression. Transparency and collaboration are 2 words we will always associate with you and your leadership. And for those of you who have not been able to be as involved in some of the planning activities associated with this group's meetings and others, please understand that Rick is not a passive operator. He has been a very involved, deeply dedicated co-chair to this work, and I know Dorothy would express the same if she was here. So as just a small memento of our appreciation for you from HILN and from the team at Healthier Washington, we wanted to present you with this award. Thank you, Rick, for your service. Well, that was the real business of today, Rick, and thank you sincerely from all of us. And so we wanted to conclude, I think, using that optimism. Sometimes I've heard it phrased this way, fact-based optimism. There are, in fact, a lot of things working in our favor. The past 2 years of leadership from this group and implementation efforts, and what the next 5 years hold, really, with Medicaid transformation. But one of the topics we didn't want to leave this meeting without delving into one step further is the role of accelerator committees and acceleration in general. In particular, you heard reports out from 4 committees today, and let me just be direct about things. Each of these committees has had passionate and dedicated leadership. Not all of these committees may continue into the future. Some of them are even having their internal discussions right now about what they want to be over the next 2 to 5 years of this effort. So with that stated, and given that I think as Peter and others have reflected today, many of you are involved here on a statewide leadership basis. Many of you, almost all of you, are involved regionally in some capacity, whether with an accountable community of health or otherwise. There are further of you that are involved very locally on a city or town-based level, that, or even within your own organization. So we appreciate that and want to be really respectful of energy levels, of time, of the significant investment that has already occurred. So with that kind of stipulated at the outset here, we want to hear directly from those of you who have been leading these committee efforts, those of you who intend to participate on an ongoing basis. What would make these, in particular over the next year or 2, worth your continued involvement? Would you guide us down the path of perhaps consolidating some of these committees so there's not as many of them? I heard one suggestion earlier around sustainability for an additional committee effort or a strand tied to ongoing accelerator committees. We don't want to lead or leave this meeting with an assumption that everything must continue as it has for the last 2 years, but want that to be informed by your direct input. So I'll pause there. We have just a few minutes left, and any committee members would invite your direct guidance to us and your comments on this topic, understanding there are a variety of directions we could take this. And our desire, our goal, is to land this kind of directionally by next meeting so we can report back to you on where we're headed and have any asks by that time outlined. In addition, as Rick is stepping back from his co-chair role, we will also be looking forward to introducing a new co-chair to this work and activity at our next meeting. I should mention that as well. Okay, the table's yours. What do you all think? Accelerator committees, where should we go? How can they be value add? How can they fill gaps? And should we be doing them at all? That's maybe the question on the table. The floor is yours.
I would just make an observation that it was very hard to not meet in person, to get things done by phone. And so having all the disparate voices from across the state was also important, but I think we were able to move simply because we can meet in person. So how to figure out going forward where we could connect in person as a committee was just one foundational thing for us. Also, I think our committee had a lot of buy-in that was sustained, but they wanted to act, not talk. So I think it would be important to shift, if you want to keep some of these folks engaged, to put them to work. And what I mean by that is they want to do stuff in their communities. And whatever do stuff means, there were certainly plenty of ideas of what to do, but I don't know that there would be much more value in convening, just to convene and talk things through. I think they're pretty poised for action.
I do see the value in the accelerator, and I do also see the value in consolidating, because we found in our committee that we do have a pretty diverse background, but you look around the room, we don't necessarily see that. We'd like to be able to integrate that with everybody else and also get some action items out of each of these, out of each of the committees, because really what we're doing, we have a group of amazing leaders in the room, but what we could get is some buy-in into what we're trying to accomplish. So coming up with some action items, or say that we'd love for you to be able to bring this back to your organization or to your ACH and say that this is something that you'd like to see implemented, that'd be really good to see, because I'd like to do some homework on the group. I don't want to just come here every once in a while and look at this as an aggregate and go back to what I'm doing. I would like to have some action steps, or I'd like to have the input from the people who really have that input, who have that, that point of view that I need to know, because I don't see it every day.
So I'll continue the theme around action and how we translate all of the thinking and the good work and the energy and the effort that's been put into the reflective part of the work over the last year or so into activity and action. Sort of the combination of action and reflection of praxis, right? What is the praxis of Accelerator Works moving forward, and what authority does the state have to push that work forward at the local level? I know there's a lot of local autonomy around ACHs, and there's a reluctance or a hesitancy to interfere with that local autonomy, and yet there's a lot of wisdom at the state level that the healthcare authority has, that you all have, that the state would benefit from. So I'm curious sort of how the A in HCA is going to be applied to the work of things happening on the ground in ACHs across the state.
Thank you. As I'm thinking about where to take this next and sort of reflecting on this comment, I think it would be a really good next step would be to take the body of work that has been developed here over the last couple of years to the ACHs, actually, because while some of us are members of the accountable communities of health, and you know, some of us are leading those efforts, I think by and large the work has really been has not been shared extensively with the accountable communities of health. And so to me that would be a logical first step to expose the accountable communities of health to this rich knowledge that has been amassed in the various committees, and then maybe enter in a conversation with the accountable communities of health and ask them, you know, how do you see yourself possibly taking some of these ideas and implementing them? That would be a suggestion that I would have.
Other questions, comments, observations?
So I like the idea of us looking at this as a big quality improvement project. So as we move from the plan phase into the, the rest of it, plan, do, study, act, really start implementing things and, evaluating them. It's easy to, fall back into the old, well, we tried that, it didn't work kind of thing versus we tried that and parts of it didn't work and we need to learn from it and keep going. So I love the idea of Winifred of integrating, this work with that of the ACHs. And sure, they need to do things in their own way, but the ACHs also have an accountability to implement, to act, and if they're not taking, the good ideas that others have used, there ought to be an open question about why not, and transparency about the performance of the ACHs. So I think it's a conversation, but if you think about accountable communities of health, who are they accountable to? I hate to say that, we need to up the ante on all of ourselves, but we kind of do, I think. Yeah.
Nancy.
I'm going to introduce maybe a new idea than what's been talked about. I don't know who is responsible for putting together the materials on the Affordable Care Act and what's at stake for Washington, but these are really great materials. And the topic is, lively. I haven't had a conversation with a friend, family member, colleague without this coming up. And so I just would love to think about how we can get this out in the community so people begin talking about facts in our state about what is at stake around the ACA for Washingtonians.
And can I jump in here too and just say something I was supposed to mention earlier and I forgot because it's come up in intervening discussions. I know there is a lot of uncertainty or trepidation about the status of the major agreement that was just signed between the state and CMS. And I should just address really directly that it is a binding agreement, and the message you can bring back to your community is we are moving full speed ahead. And I'm very optimistic, given the nature of the agreement and the precedent behind demonstrations of this nature, that we're on very solid ground. And would add the anecdote that when we were presenting a group of us from HCA to the Senate Healthcare Committee, it was the chair who had just spoken with members of the congressional delegation from the Republican side who expressed absolute confidence herself in the work of the demonstration moving forward. And I think it's good to listen to those voices and those more attuned to the DC political scale. But just wanted to drop that in today's discussion to the extent in your own circles you're hearing some of those doubts or uncertainties. We're moving forward with absolute confidence and determination, and I want to make sure people are aware of that. Okay, I cut somebody off. Kathleen, here.
So thank you for sharing that. And this is a comment I made earlier too. First, I want to say, Winfried, I totally agree with your idea that we should take this work out to the ACHs because we have done a lot of great work here, and they should see that and determine whether or not it's of value to them, and if not, what can we do to make it more helpful for their work. And then secondly, thank you. And knowing now that we are full speed ahead, it would be great to broaden the public conversation about this work so people really understand the connections and really can advocate in their own interests as we're moving forward.
Perhaps I can briefly respond to that too, because I'm about to go hop on a ferry as soon as this is over. So I'm going to be running out of here to our first regional discussion of Medicaid transformation hosted by the Olympic Community of Health. And we have 8 more of them planned. They've been calendared. Locations are still, some of which are being still determined logistically. But maybe we can take as an action item, making sure you all see as a separate email. The broad communications have gone out, but we'll get a separate email about these regional opportunities to engage, in particular on the Medicaid transformation, but it's being presented against the broader backdrop of what we're doing with Healthier Washington. And beyond us. And the whole intent of it is to engage members of the public and others who will be partnering in this work. So we'll get that out to you, and then please disseminate further as appropriate. And we'll even try to turn that around as soon as today.
Final question, final comment? Hearing none, thank you much. Have a great week. Safe travels.